Okay. All right, so welcome everyone. My name is Regina Lehman. I'm an occupational therapist, and I have been an OT for over 35 years. I practiced in mostly physical dysfunction settings, but across the lifespan, from infancy all the way up to the older adult. I have expertise in cardiovascular and pulmonary disorders. I have been involved in actually creating a cardiac rehab program in an acute care hospital with OTs and PTs. So I author these chapters. So hopefully I will be able to respond to any questions that you have. My audio sounds a little muffled. Is that true? Can everyone hear me? As I said, I was having some technical difficulties, so please put in the chat. Can you hear me? Okay. All right. If it starts to be a problem, someone just unmute and let me know. Okay. So let's see. As there we go. As with all of the online office hours presentations, the session is the property of Therapy Ed. So the session's being recorded and it will be posted on the Therapy Ed YouTube channel at some point and be available to you if you'd like to review anything. Please don't take any pictures or screenshots. We are very protective of our copyright and the fact that we are the authors of this material. Okay, so I appreciate your compliance with that and the code of ethics. Please keep your mic muted. Please do turn on your mic if you're invited, when you're invited to share questions. If you have a comment, you can feel free. It's difficult for me on Zoom to see the participants, as you are probably aware. So I won't know if you raise your hand immediately. So if you have a question and you need me to stop to re-explain something, you can go ahead and unmic and just say, Regina, could you repeat that? Or I need some clarification, but I will leave plenty of time at the end of this session for Q&A. There is no co-host anymore. It's just me. So if I don't get to you in the chat and there's something there, I'm not ignoring you. I'm just going to try to keep an eye on that so I can stop intermittently to respond to any questions. So this is a review of the must-know content for the cardiovascular and pulmonary systems disorders chapters in both the OT and the OTA review and study guides by Therapy Ed. So I'll be referring to those chapters, and it's chapter 8 in both books. So here are the top 5 things that are definitely on the OT and the OTA NBCOT exams. You can be sure that coronary artery disease, that is one of the top diagnoses in the country, that it will certainly be making it to your exam, and most likely associated with myocardial infarction or heart attack. So you should understand something about the way the circulatory and the pulmonary systems work together. That's something that's important to have in your repertoire as you begin to look at these conditions. One system influences the other pretty intimately. All right, so coronary artery disease, as you know, right, is a thickening of the walls of the arteries, which then impedes blood flow. Pieces of that plaque can break off and cause all sorts of problems. You should be taking a look at some of the main clinical symptoms or syndrome, signs and symptoms of CAD. Probably one of the top of those would be angina or chest pain. Safety questions around angina occur relatively frequently on the NBCOT exam. So that could be an indicator that maybe it is foreshadowing an MI. It could also just be an indicator that there's difficulty with blood flow. It can be incapacitating. And then depending upon, how severe the symptoms are, you should also be aware of if someone's experiencing angina during a treatment session, you might be asked to administer sublingual nitroglycerin. Right, so there's stable and unstable angina. So go back and make sure that you're reviewing all of that. It is also a red flag, right? If you're working with someone. And so an MBCOT question might say that during a session, the person is status post MI, 3 days during a occupation-based intervention, the client reports severe chest pain. What should you do immediately? And that's obviously stop. Vital signs, perhaps sublingual nitroglycerin. So they'll be looking for you to kind of know those steps. All right. There are, excuse me. Okay. The review and study guides do a really nice job with the red flag boxes related to angina and what to do. There, and obviously, you immediately cease the treatment session, take vitals. You might have to administer medication or help the client to administer their own medication. Monitor the symptoms, you contact the physician. But the very first thing always is just to stop the activity. There are some really nice charts and things like that in these chapters as well. Understanding what heart failure is, okay, as opposed to coronary artery disease, is also really important. And understanding the difference between right versus left heart failure. And in the updated book, I'm looking, it's not table 8.1, is it? It is. Hang on one second. It's table 8.3. So I have to update my presentation. I'm sorry. I'll give you the pages and everything. So table 8.3 has to do with heart failure, and you should know the difference between right and left. Left heart failure has much more pulmonary symptoms related to it. So there's dyspnea. You should know what that term means. Orthopnea. There is, excuse me, it could be wheezing or wails. So left is lung. That's the way I remember it. And then right ventricular failure has to do more with dependent edema, weight gain. There could be, excuse me, there could be real circulatory issues. So there could be trophic changes, maybe cyanotic changes to the nail beds. So that's another way to remember that. But you should know the difference between the two of those. And that's table again 8.3 in both books.
I'm sorry. Did you just say that you remember the left heart failure and you say lungs? That's what you...
Right.
Oh,
yes, I did say that.
okay.
Because left-sided heart failure has a lot of pulmonary symptoms related to it. Right, so dyspnea is shortness of breath. So I think about the lung there.
Oh,
that was.
Thank you.
You're welcome. So just as an update, while I'm looking at the slide, in the OTA Review and Study Guide 5th edition, the pages are chapter 8 starts on page 282. And in the OT Review and Study Guide, the chapter starts on 298. Okay, so those pages there are again the old edition. Right, so those are the new chapters. The new books, the new Review and Study Guides do a nice job of kind of condensing the anatomy and physiology part of it. So what's in the beginning of this chapter, don't just disregard it, do it as a review. So that you have an idea, well, what is the connection between the heart and the lungs and the circulatory and the pulmonary systems? Okay, so that was one of the reasons why I emphasized left heart failure and the connection to breathing. Peripheral vascular disease is just that. It is a disease of the vascularization of the peripheral system. So we see it commonly in several diagnoses. The one that always comes to mind for me with PVD is diabetes. So along with peripheral neuropathy with diabetes, we often see some peripheral vascular disease as well, right? So it can be a chronic condition. I'm looking because somebody put something in the chat for right-sided. For right-sided heart failure, dependent edema means that it's usually in the lower extremities. Good question. That was a very good question. Okay, so dependent means that if your legs are down, right, gravity is not just a good idea, right? It's a law. So the gravity actually brings the fluids, because what's happening is, again, if you think about the lymphatic system, it's also part of circulation, right? And if that system is not working properly because of right-sided heart failure, you're going to get dependent edema. You're welcome. One of the big danger with peripheral vascular disease, of course, is, excuse me, is that it could lead to a clot, and a clot could break off. And hang on one second, I have somebody coming into the room. There we go. You could get a thrombus, right? And that blockage could potentially block an artery in the heart. It could also break off and cause stroke. It could cause a pulmonary embolism. So we really want to make sure between coronary artery disease and peripheral vascular disease that you're thinking along those lines. The other thing that happens with PVD, if an area is not vascularized, circulation is compromised, and you could get a pressure ulcer there. So you should be reviewing the material related to what are the signs and symptoms of potentially a pressure ulcer from happening, and how would that get treated? Okay, so DVT, I mentioned that, right? So peripheral vascular disease, when it has to do with deep veins, could cause a DVT. And there is a chart, a table on table 8.7 that gives you all of the different kinds of peripheral vascular disease, whether it's arterial, it's venous, or it's lymphatic. So you should take a look at that table as well. I apologize. Moving into the pulmonary system, the really big diagnosis that is always on the NBCOT exam is COPD. However, you should really make sure that you are also looking at pneumonia, and looking at RSV, right? The respiratory virus. Information about tuberculosis is also in the chapter, but I would say that COPD is definitely a must. And you should understand what that means, right? So obviously, what are the signs and symptoms of COPD? Someone's going to have difficulty with activity. They may become short of breath. What does that mean? How would that get handled? So those are all of the things that you need to know. You need to also know that, what should oxygenation be related to taking pulse oximetry? Once somebody falls below 90% on room air, we're thinking about nasal cannula oxygen for activities. what kinds of theoretical frameworks might we use with someone who has a chronic disease as opposed to an acute disease? So coming from the perspective of thinking of an MI as something that the person, they have a heart attack, they have cell death in their heart, they have damage, we're looking at risk factors, and then we're really thinking about bringing that person back to a previous level of function, if possible, with more restorative. With COPD, we may be thinking more about compensatory techniques, work simplification, energy conservation, environmental modification. So again, of course, it would depend, but I'm thinking acute condition versus something that's chronic, and we know is not going to get better, right? COPD doesn't resolve. There's medications to manage it. There are, different dietary things to help manage it, but it's a chronic disease that, left untreated, obviously would really be fatal. Okay. Some of the medications that are, involved here, you should make sure that you're at least looking at classes of medications for both cardiac and pulmonary conditions. So you should know what a beta blocker is. You should know what, as I mentioned, sublingual nitroglycerin. You want to be looking at some of the classes of medications. Oxygen therapy, monitoring oxygen level for COPD is really important. We might be doing patient teaching about that. So anything that might involve some health literacy is also something to keep in the back of your, keep in the back of your head. The information that I can share about cardiopulmonary rehab and MET levels and activities, etc., is, obviously the focus of rehab is dependent on, in many ways, right? Thinking pragmatically, where is this person being treated? So is this an acute episode? Did this just happen acutely? We're seeing that person in the inpatient acute care hospital and only have a few days. Obviously, if it's someone who's had a major heart attack, or a major MI or a major event, and we're thinking about MET levels, they're going to be relatively low. We may or may not see that person get out of bed right away. We might be waiting a day or two to see how they do. And then, those transition. So look at the continuum of care. Think about acute care. Think about, is there what rehab looks like? Are they going to an acute rehab, or do they tell you that the person's in acute rehab? Are they in a subacute rehab? And what the functional level is. So the biggest question that I usually get asked is, how do we remember all those MET levels? And my general advice is to say that look for changes in position. So when can the person shower in standing? Right? What kind of MET level would they be able to tolerate? So look at things as at MET level 2, most activities are done bedside. When we start to go into MET level 4, we're looking at a higher level of tolerance, a higher level of ability to handle activities. The other piece of rehab that is important is vital signs. So make sure that you're reviewing, what are the vital signs, respiratory rate, blood pressure, oxygenation, what kinds of instruments do you use? What are you expecting, a normal adult blood pressure to be? Because if it says something in that you say in an exam item, you say, wow, that's really high, what it would be asking, what would you do? Sorry. Let me think. again, the OT process is the OT process. So we're starting out with an occupational profile or an interview or a chart review. And then we're, prioritizing what occupations are important for that person. Table 815 is the MET levels table for common activities. And you can see that obviously those very light activities at the beginning, 1.5 METs. That's not a high level of activity at all, right? So there's probably a level of assistance required. I would think about MET levels that way also. What would the caregiver burden be? If a person can only eat their meals in bed, or they need help with grooming and washing, then that burden of care is going to be higher, as opposed to when they're able to achieve MET levels of 3 to 6. And that's a pretty nice 3 to 6 is a pretty good active rehab program in a rehab site. And interventions are going to obviously vary by patient. Hopefully, you'll be looking at some occupation-based interventions in the questions that are asked. You have to make sure you're reviewing your dyspnea control, right? So things like dyspnea control postures, thinking about pursed-lip breathing, diaphragmatic breathing, really thinking about how to help someone, increase their lung capacity. And that goes for both cardiac and pulmonary. We see it most often with COPD, right? That's where we start to really think about dyspnea. But somebody post-MI or who's had heart failure could certainly be having difficulty breathing. Okay, so, all right, let me see. Okay, so do you all see now the exam item of the week? Somebody just say yes or no. Okay, good. Thank you. All right, so this was the exam item of the week. And let's see, I'm gonna move that so I can see it. There it goes. So the person's complaining of dyspnea during home management activities. So this person has mild COPD. So what would be the best for the therapist and the OTA to include? We just kind of talked about that, right? So, let's see. Right, pursed-lip breathing would be the answer. And I like this rationale. Dyspnea is shortness of breath. And dyspnea can occur at any point during the completion of an activity, right? So the person gets started, they start to have difficulty breathing, they complain of shortness of breath, and pursed-lip breathing helps to control breathing and also helps with ridding the lungs of carbon dioxide. Because what happens with dyspnea is that the lungs don't completely empty, so there's a buildup of CO2 in COPD. All right, I see a whole bunch. Let's see, was it just yeses? Okay. Can you show the choices again? Sure. Hang on a second, let's go back. There. So the choices were to teach the person to check the respiration rate, the monitor their blood pressure. Oh, sorry about that. There we go. Okay, there we go. Hyperventilation strategies sound dangerous to me. Or pursed-lip breathing. Okay. Okay, so again, I'm seeing a couple of questions. Hang on, and I'll get to the question about diaphragmatic breathing in just a moment. All right. Okay. So. All right, I am going to. I'm going to come back to the Q&A in just a second. In fact, what I'm going to do is I'm going to pause the recording. There, oh, that's pausing my share. And